Hello, good evening everyone, and welcome to 365 Live. My name is Kamin, and I'll be the host for tonight's live session. 365 Live is a platform where we educate the public on cancer and encourage a cancer prevention lifestyle. Whenever you see this logo, you'll know that the 365 Cancer Prevention Society is currently having a live broadcast. Just a gentle reminder that all information shared at this event by the speaker and 365 CPS are general information only and subject to changes. Do consult your doctor for personalized and detailed medical advice. So without further ado, I am pleased to introduce tonight's speaker, Dr. Francis Chin, an experienced radiation oncologist with more than 20 years of experience. He is Deputy Chair of the Institutional Research Boards in Oncology, Hematology at SingHealth with appointments with HSA, DSRB, IRBX. Dr. Chin is also a recognized local and regional expert in radiation biology and a chapter author in the Oxford textbook of critical care on radiation poisoning. So tonight, he will be sharing on radiotherapy in curative and palliative treatment. Hello, Dr. Chin.
Hello, hi.
Thank you so much for joining us tonight to share your knowledge with everyone here. I will hand over the time to you, Dr. Chin. Thank you.
Thank you very much, everybody. My name is Dr. Francis Chin. Very pleasure to be here today to share with 365 and all our clients and everybody tuning on the Facebook Live feed. And firstly, what is radiotherapy? Radiotherapy or radiation therapy uses X-rays to treat cancer, and we destroy cancer cells by targeting these cancers. It reduces the growth and spread of these cancers, and it uses the variety way that we can give to relieve cancer symptoms. So radiotherapy is generated as a form of X-rays, and it is by creating high energy voltage electrons striking a metal target, creating an effect, creating a Bremsstrahlung effect, creating X-rays, and these X-rays are directed to the patient and then targeted to the cells. They attack these cancer cells, and the modern radiotherapy machines can very accurately target certain cells which are cancerous, limiting the damage to the healthy cells. Because these cancer cells have DNA damage, they are more sensitive to radiation, and the damage of radiation is further limited because small doses are given over a period of days and weeks. Throughout this time, the normal cells can actually recover from radiation, but the cancer cells being targeted, the target of the radiation is actually on the X-ray, on the DNA, and over time, these cancer cells which have abnormal DNA repair mechanisms will actually experience cell death and die, but the normal cells can recover, and over time, more and more cells are left behind compared with the cancer cells. Being an X-ray, we know that radiation is not painful, and we can accurately target whatever the region being treated. Normally, when you go to a doctor for your X-ray treatment using radiotherapy, your treatment is from Mondays to Fridays, 5 to 10 minutes delivered precisely to that area. In certain parts of, if it is given as a palliative dose, sometimes it is given every other day or even once a week. There's usually no hospitalization required, and the patients can return home daily. These are just some of the pictures I would like to share about the types of radiation machines that we use. This is a bunker. It looks like an X-ray. There's a big linear accelerator behind, which generate X-rays, creating the beam which strikes a target. And then this beam is actually highly focused onto the X-ray head normally, and then delivered to the patient, which is lying on the couch. Usually, an X-ray is taken so that the patient, we know the position of the patient, and then a plan is actually delivered as well based on, the X-ray is delivered based on the plan. There are many, many different types of radiation machines. We have linear accelerators. We have high-tech robotic cultures. We have also tomotherapy, and we also have recently proton therapy in Singapore. How do we say this? It is because like different cars have different specialties to be used. Some cars are very good at doing certain tasks, and there are very specialized machines that we can use. In general, we have radiotherapy machines that can image as well as treat very precisely treatment targets. Certain things like proton therapy have very specialized indication because of the unique properties of the proton therapy. It is called a Bragg peak phenomenon, where the proton is actually accelerated and then shoot into the target, and then there is actually very little exit dose. It results in a better dose distribution and minimal damage to the surrounding cells. It is best used for pediatric patients and also in places where it is close to critical organs like the brain, the eye, and the spinal cord. Other radiotherapy machines are very good at imaging, and then we have very precise indicators that we can see where the X-ray is, and then we treat them. There are many different types of radiotherapy. There are many terms that are being used. The earliest form of radiotherapy is what we call 3D conformal radiotherapy, which is very similar to X-rays, where before the computers were very advanced, these are the type of X-rays that we will use with an open field, and we still use it today, treating patients who are palliative, who require quick planning, easy setup, so that the patient is not on the couch for a very long time. And it is still used very often, and over time, more advanced algorithms are developed as the machines got better and better. You may have heard of IMRT, which is intensity modulated radiotherapy. What happens is that there is actually leaves called multi-leaf collimators inside the radiotherapy head, which come in and out, and they modulate the ray given, resulting in a more nuanced waveform that can deliver and vary the intensity of the rays being treated, shaping to the size and the shape of the tumor. If we add imaging in the form of KV X-rays, we have what we call image-guided radiotherapy. As we develop more and more advanced techniques, we have what we call stereotactic radiotherapy, which later I will show you a form of. There's again proton therapy, which I alluded to, which uses large machines to actually accelerate a proton particle, which is used then to shoot onto the target to the patient. And this unique property of the proton is that it does not actually have any exit dose. So we can be able to conform a dose very carefully. But currently, the proton beams that are being used in Singapore are what you call pencil beam proton beams. The beam is very small, highly specialized, and it's only approved for certain indications. We also have types of radiotherapy which are permanent implants, and internal radiation therapy, what we call brachytherapy. This is just a workflow showing how we treat a typical breast patient. Firstly, there's a consultation which the doctor will see the patient, and then we'll decide what, and we'll consult the patient, telling them about the possible side effects, the indication, and then we will send the patient for what we call a CT simulation, which is where we actually image the patient, because each patient is different, and individually everybody has a different size and shape. After imaging, we send this plan for planning, where we contour every single slice of the body, including the area that we want to target. We plan this using advanced computers, using multi-color algorithms, and it takes 3 to 5 days, and even up to 2 weeks. We get a good plan, and we need to do quality assurance, post-plan verification, and then we have the patient in, where we start the first day, and then we set them up, we deliver the treatment, take an image, and then we check. And then there are many checks throughout the period. And then we will always check. The doctor usually reviews the patient once a week while he's under radiation treatment. Radiation is an essential part of cancer treatment. It is one of the main ways to treat cancer, together with surgery, chemotherapy, immunotherapy, hormone therapy, target therapy, and coming soon, stem cell therapy. It is said that radiation is a way, I would describe it as doing surgery using X-rays. So it is very useful for a variety of cancer cells or cancer types where one is not able to do surgery, and then we can use radiation to treat this. What is the cancer burden in Singapore? The top 3 cancers, we know that cancer is one of the top 3 killers, together with heart disease and stroke. And among the cancers, it is usually breast, colorectal, lung, prostate, and gynae. And we know that the incidence is rising year after year. Among the females, the top 3 are breast, colorectal, and lung. Among the males, the top 3 is colorectal, lung, and prostate. These are all cancers that require radiotherapy in one form or another, in coordination with surgery and chemotherapy. Again, this is another chart showing the new cases by diagnosis almost 1.5 decades ago. But the main takeaway from this slide is that the number of cancers are increasing over this period. And we can see a rising trend even among younger females, breast cancer being number 1, but also colorectal and lung rising together with it. Among females, colorectal, lung, and prostate is the number 1 cancers. So, is radiotherapy required for all cancer treatments? In general, it can be given as a radical cure treatment, and I have said, and also adjuvantly for cancers where the tumor has not spread. Cancers can be divided into early cancers as well as late cancers or advanced cancers. In general, if it is a stage 1 to 3 cancer, for example, for breast, we would normally either have surgery first, followed by chemotherapy, then followed by radiation for the adjuvant treatments. Or if this is already an advanced cancer, what I mean, if this is a stage 4 cancer and no cure is possible, we can, and usually we will not advise surgery for these sort of patients. Radiotherapy is one of the pillars, together with chemotherapy and is given palliatively to relieve the symptoms of tumors which are advanced. Palliative means to reduce the pain of these cancers. And what can we reduce? We can reduce pain. If a cancer is bleeding, we can, after radiation, usually reduces the bleeding. And if there is intestinal obstruction, we can also give radiation to clear this obstruction. So the top three uses palliatively for advanced cancers, especially if, let's say, there's colorectal cancer and we see the patient is bleeding, we will give radiotherapy either 5 to 10 times, and it relieves the pain, bleeding, and obstruction. What cancers can radiotherapy treat? Anything that can be treated with surgery usually can be treated by radiotherapy. It is used sometimes to downstage a cancer. In an advanced breast cancer, after we treat with radiotherapy, we can see that the tumor shrinks, and we often coordinate with our medical oncology colleagues. It is also used adjuvantly. When I say adjuvant, it is used to treat small microscopic cells. After surgery, after chemotherapy, we use radiotherapy to mop up small cells which we feel are at risk of recurring if no further treatment were given. In many stages of lung, breast, and colorectal, radiotherapy still forms an integral part of the treatment. And it is also used as radical or primary disease treatment for head and neck cancer cells, esophagus, GI, and gyne-like cancers like cervixes. This in itself forms up to 30% of all cancer burden tumors. In essence, these are the ones which are difficult to treat with surgery, and if we have done surgery, it will result in too morbid an operation. So radiotherapy is used to radically treat these early and advanced cancers. If you have a cancer diagnosis, it is very likely to require radiotherapy. Up to 80% of all cancers will get radiotherapy in part of their treatment life cycle. And we are not able to cure all patients. Some of them, and up to a third of all Singaporeans, will die of cancer. It is used, and in up to 2/3 of all cancer patients may require some palliation of symptoms. It is used to relieve symptoms of obstruction in gynae cancers, in GI cancers, prostate, or if you have a head and neck cancer obstructing an airway. It is used for bleeding. If you are bleeding from a stomach cancer that is not able to do operation, sometimes we do radiotherapy to give to these cancers and to dry up the bleeding. Radiotherapy can also be used to relieve pain, and it's usually very effective if one has bone mets and causing pain, or if there is a lump causing nerve enwrappment. Usually when we treat with radiotherapy, it relieves the pain. You use it also if it's spread to major organs like liver, lung, bones, and brain. We are able to give a good quality of outcome to all our patients with terminal disease so that they can have a better quality of life for the rest of what remaining life there is. What are some of the reasons for giving radiotherapy? We downstage tumors also for complete resection, especially for large tumors. Some of these large tumors, we can use radiotherapy combined with, in rectal cancer, combined with chemotherapy. We can make it smaller so that patients, when they undergo surgery, they may actually have a smaller surgery leading to a sphincter sparing surgery. It decreases local recurrence risk in some of the more advanced cancers, increases the cure rate. And for the patients who have undergone, for example, endometrial or cervical cancer treatment after surgery, we can treat the draining lymph nodes in the pelvic brim, because often the surgeon is not able to clear extensively the lymph node because it is next to vital vascular organs. So not much margin can be taken. So radiotherapy forms an integral tool to actually sterilize these areas where there may be possible microscopic tumor left behind. We also use radiotherapy as a prognostication tool. Prognostication is just to mean we can know what is the outcome. If the patients have good response from the early treatment of giving radiation and chemo before surgery, they usually have a better cure rate. Again, just a repeat of the slide. Radiotherapy works in concert with the surgeon, with the medical oncologist, and with the various immunotherapy, hormonotherapy, targeted, or even stem cell therapy that is coming. And it's one of the major pillars that we still use to treat cancers. This is just a slide to show what a typical plan for. We have many advanced technology. For example, this is someone who has undergone breast resection, and then now we are treating the chest wall. There's a CT scan done, and then we contour in the chest wall, and we do a computer calculation and planning. In this picture, the legs are out, and then the head is into the screen. So the area in colored and depicted is the patient's left side. And being the left side, in the old technology, we are worried about dose being delivered to the heart and also excessive dose to the lungs. But we have computer calculations now that can have the machine head go round and round in what we call volumetric modulation, arc therapy. That arc therapy is like a CT scanner that goes round and round, delivering the dose to the chest wall. And we can calculate the dose and do a plan before we actually deliver this plan to the patient. And the top right-hand corner is a dose histogram, which gives us this dose given. The doctor will evaluate and then approve these plans if it passes various protocols. This is an example of someone who is receiving head and neck therapy. And after contouring, the physicist would put in these fields, and we can see on the CAD plan what it looks like. And you can see the various windows where the linear accelerator will come in and conform to the shape of where the tumor's being treated. We have many advanced cancers that require treatment. This is an example of stereotactic treatment for a head and neck brain tumor patient. They usually have a mask that is made, and it's locked onto the bed, and there is balls that we use to actually triangulate so that we know in spatial space where the patient is. We have x-rays that will take this patient, and after that we have computers to actually direct the treatment. So in this patient, there is a tumor behind the eye, a craniopharyngioma, and a pituitary tumor, and we contour out the eyeballs, the nerves, the optic chiasm, and the brainstem. We want to deliver very little dose to these areas. So what happens is that we will take an x-ray, acquire the first image, take another x-ray, acquire a second image, And this is like a stereoscopic picture, like your 3D glasses. So this is the first image being taken, and then this is the second image taken. We will compare against the plan. And if we find that there is a slight deviation and discrepancy, the 6D couch will automatically change the shifts such that the deviation is corrected and the alignment is perfect. And you can see from the numbers below, the correction is just in the XYZ direction, and it's usually just sub-millimeter correction, 0.5, 0.2, 0.2, with small degrees, but we want to make it align perfectly before we start the treatment. We check, the therapist will check these areas, make sure that everything is perfect before we deliver radiation to these patients. So this is an example of radical high-dose treatment to these areas, and we are able to deliver a degree of very high-dose precise X-ray treatment for someone who has a brain tumor using these sort of machines. And there are many, many machines similar to this for different types of cancer that we would use. For prostate, we may use a VMAT machine. For head and neck cancers, we may use IGRT. Nose cancers, if there's a pediatric patient, we'll use a big proton machine. So it is the doctors diagnosing will be able to advise what machine to use and be able to appropriately direct the patients to the correct machine that we need to treat. There are, again, we go back that there are breast, colorectal, and prostate. And then a lot of these patients are, I mentioned that normally we treat them Monday to Friday, but if there are palliative patients, normally we have shorter treatment regimes between 5 to 10 times, and they are finished usually in either 1 week or 2 weeks. So I'm almost to the end of my presentation. I'm also a consultant besides radiation, but also in palliative medicine, where we use medicines to actually relieve pain and take care of patients who are in their dying days. And radiation actually forms a big part of this because there are many instances where the cancer has spread into the brain, and we deliver targeted doses to these cancers so that the patient does not experience side effects like in the old days. Now we are able to precisely give what we call stereotactic radiosurgery to the brain mets, such that the patients do not receive what we call whole brain therapy, and they result in better quality of life in the little time that they have. So I have almost reached the end of my presentation. Is there any questions from the journal?
Thank you, Dr. Chin, for your comprehensive and informative sharing. So I also have a better understanding of radiotherapy and how it actually relieves symptoms of pain and bleeding and have a better cure rate. So I hope that everyone now online has learned more about radiotherapy in curative and palliative treatment. So if anybody has more questions, please feel free to share in the chat below, and we will address them accordingly. So now I see we have quite a number of questions from the Facebook chat. Okay, let me read them out for Dr. Chin. So Claire is asking, will radiotherapy affect one's fertility? If so, how can it be prevented? Thank you.
Okay, so the question is whether it will affect the fertility. Depends on where we are treating. If we are treating the head and neck, then it will not affect the fertility. Where it is quite important to be quite precise is in instances that I can see where we treat gynae cancers. But in a lot of all these gynae cancers, they would already have operation, what we call THBSO, total hysterectomy, bilateral salpingo-oophorectomy. So these are already they are not fertile anymore. But there are a small group of patients, and I do see them because I do gynae and cervix cancers, that in very young patients, when we do see cervix cancers, or early cervix cancers, then yes, when we actually give radiotherapy, the ovary is very sensitive and we need to treat the entire pelvis, which is the gynecological complex. So in these patients, because the cervix is being treated, because you have a cancer there and the uterus is being treated, sometimes the fertility rate is down. But these cases, fortunately, are very low and small because young gynae cervical cancer rates are coming down because of our good HPV screening, as well as our very successful HPV vaccination. I expect in about 10 to 20 years' time, cervix cancers will be a dwindling cancer diagnosis.
Okay, noted. Thank you, Dr. Ching. So we have another question from Karen. So she's asking, can proton radiotherapy be used for stage 4 lung cancer and cancer at the pancreas?
Okay, currently, proton therapy, there is a very specific indication that is only allowable in Singapore, that we are saying, and the government has decided that it can only be used in curable cancers. In general, once the cancer becomes incurable, it may not benefit so much from proton therapy, and it is an expensive therapy that they have decided what can be used for it. So once it's a stage 4 lung cancer, it may not be used. But if you had stage 3 or stage 2 lung cancer, then proton therapy is one of the approved indications for using proton therapy for treating lung cancers as well as esophageal cancers.
Okay. And we have a question from Sebastian. He says, I believe radiation exposure is one of the reasons that causes cancer. So he's asking, will radiotherapy then increase the risk of other cancers too?
Yes. So it's been proven, or it's been from the studies, that radiotherapy interacts with the cellular DNA, and normal cancers can actually repair the damage compared with uh, abnormal cells which do not. And hence, this is the mechanism of how we use radiotherapy to treat cancers. There is an unintended sequelae that in 1 in a million, or in a certain percentage of cells, radiotherapy exposure causes normal cells to mutate, and then there is a chance of turning cancerous. But this chance is well documented in, for example, a large group of patients who had undergone Hodgkin's lymphoma treatment. Part of their treatment, they had received chemo as well as radiotherapy. We find that 20 years later, there's a small proportion of patients who then develop breast cancer. Having said that, the doctor will usually, and it is an established protocol, that we have to actually use radiotherapy to treat these cancers, because if you do not treat, you will not even have the chance to develop breast cancer 20 years later. So it is a small side effect. Usually, I would say it's about 1% increased risk of cancer over 10 years. So we do not give radiotherapy lightly. We, the risk of 1% over 10 years was due to machines that were very, very old, Now we have more precise machines that will reduce the dose delivered. Ultimately, we expect or we hope that the risk of cancer genesis is actually decreased. In the very same way, chemotherapy given can also create the same carcinogenesis, especially for alkylating agents. So there is a move towards reducing alkylating agents in your chemotherapy. There's a move towards reducing extra dose by better technologies like proton, with better technologies like more precise VMAT. So in a way, it's a dilemma. You have to treat because and the benefit of treatment far outweighs the theoretical risk of developing cancer in the future. If you don't treat, you may not even have that chance to actually cure.
Okay, so it's important to
To
go
weigh
for
the risk,
checks.
yeah,
Yes, to
and
weigh
go
the
for the
risk.
treatment, yeah.
Okay, and following up on this, we have a question from Des. So he's asking, how can we check for cancer for the whole body? Is there a program that allows the public to have their overall body checked?
Okay, firstly, I think the question regards to cancer screening. There is still currently no whole body program, although we hear that in some parts of the world, there are people who do whole body MRIs or even PET scans to check if there are any abnormalities, but it is not recommended at the moment, this sort of imagings. What I would suggest for everyone is to follow the 4 established cancer screening guidelines because everything is respect to risk. You know, in the same way, it's a bit like buying insurance. Can I buy insurance for every single thing? You know, earthquake, typhoon, loss of theft, loss of planes. In the end, you will just need to do the best that we can based on the risk of where you're going, and then buy the proper insurance. So when you want to check your body, it's as if you have a car that is, if it's a brand new car, if you're very young, the chances of finding something is pretty low. So you start only servicing or checking your car when it's reached a certain age, maybe 5 years, where the government will say you have to bring it in for Viacom check, yeah, and then they will check 20 things. They will check. So this is like life screening. We start at age 50, and then we'll do colonoscopy, and then the other thing and 365 is doing, we are programming whether we check for fatty liver. We also check for lungs. So there's a program that 365 is we have. The national screening guidelines for women, because breast cancer is very high, we do mammograms. If you're very young, you will need an ultrasound because the breast tissue is very dense. But in general, we only start mammogramming women from 50 onwards. But we do hear of younger and younger patients getting breast cancer. If we are worried, especially if you have a family history, then you may want to do a cancer health screen earlier on. It's very easy to do a pap smear. Everyone who has delivered or goes to the gynae, women will actually receive a letter from when they are from age 25 to actually go for a pap smear, you know, and because of that, the cervical cancer rates have come down dramatically. It's one of the success stories of Singapore. We also have a fecal occult blood screening where I believe 365 is so involved. You ask for a envelope, and then from your home you send via post, and then they will check if there's blood. If there's blood, then they will offer you a follow up, and then the follow up could be the form of consultation further on, plus minus colonoscopy. So there are many ways to check. There are some aesthetic screens where they do tumor markers, but the tumor markers are not 100%. There are some tumor markers for breast, for pancreas, for GI, for lung, which are major cancers and very important. There are markers also for ovarian. But in general, the yield of just doing a random tumor marker is very low. And also tumor markers for prostate, PSA, which are very high cancers. There are some tumor markers for nose cancer, EBV virus, but these are very low yield because the incidence in the normal population is low. It is more likely that you get a false positive reading rather than being very useful and then you get all anxious for nothing. Because screening relates to how common the incidence is, and there's a certain calculation that if you do something in the same way, when we scan for a lung and we find small nodules, it may be a false negative that not all these small nodules are cancer, and it results in a lot of unnecessary screening, necessary anxiety, and investigations. Yeah. So always visit a doctor because it is individualized to yourself. Whether you are 60 years old with history of diabetes, family history of cancer, then you probably need to screen earlier, and the doctor can advise. But if you are just a normal individual and with normal risk, uh, it is quite low risk, but it's always good to actually, and I encourage people when they go for screening, it is not the tumor markers that you're worried about. You should actually check your diabetes and your cholesterol. Yeah, because these are the two together with cancer, is heart attack and actually stroke that we are worried about. And then these are the ones that you want to keep a measure of, whether your blood pressure is good, whether your blood glucose is good. Once you've done that, your cancer risk or your mortality risk is quite low.
Des and Sebastian says, thank you, Dr. Chin, for your sharing. Okay, and we have a question. So bringing it back to the previous question, Dr. Chin, you mentioned that the effect of treatment far outweigh the risk of going through radiotherapy. So actually, would patients be able to have the choice to opt for other treatment options if they are worried about the risk that radiotherapy might bring?
Yes, certainly. But I would actually advise you to talk to your doctor. There are certain things that uh, it is an established regimen where we know that the benefits clearly outweigh the risks. And it would be irresponsible of me not knowing your particular condition to say you can actually replace it with something else. In some situations, radiotherapy actually replaces surgery because, for example, for if you have a larynx cancer or nose cancer, and it is very hard to operate or almost impossible. In these cases, radiotherapy is almost mandatory because there is no good replacement for it, to treat these cancers for cure. But in situations where adjuvantly, where you've already taken out the cancer and they have just talked to you, this is to reduce the recurrence rate, then you can, of course, have a frank discussion with your doctor, clear your doubts on the side effects and the potential side effects. Because nowadays, with modern radiotherapy techniques, the side effects of cancer or second cancers is very low. To give an example, we are always worried about, I've heard when I take a plane, the plane can crash. It's a metal piece up flying in the sky. It's abnormal. I heard of so many planes crashing on the ground. Does it really mean that now I will not go traveling or flying to another country and I will just walk? Yeah. So there is a certain risk which is very low because the machines and treatments that we do now are very safe. It's very safe to fly. Once in a while we will hear of a plane crash, and then, but we still want to go for our holidays. The benefit of this being on the plane far outweighs the small theoretical risk of it crashing.
Oh, just now when Dr. Chin was talking about the side effects of radiotherapy, there is a question here. So, how long might the side effects of radiotherapy last, and how
Okay.
can it be avoided if possible?
Okay. So the side effects of radiotherapy can be divided into two broad groups. Acute side effects are side effects happening within the first 3 months, and then long-term side effects, those which happen more than 3 months. And the side effects relate to the area being treated. There are general side effects, like similar to chemotherapy, where there is tiredness, nausea, and vomiting if we treat certain places. So, and there are also specific side effects if you treat the head and neck region. Okay, and the immediate side effects in the next 2 to 3 weeks after the start of radiation, you get reddening of the skin around the neck. You have mouth ulcers. You have dry mouth. Taste changes. Okay, uh, when you see the doctor, the radiation oncologist, they will give you general advice, supportive medicines, and interventions such that we reduce the side effects. But the best way to reduce these side effects are actually to have a good radiation plan with a good modern machine, accurately shooting the cancer, but avoiding the normal tissue, so the side effects can be reduced. There are certain medicines that we can use, but the best way is actually to reduce the dose to the normal organs. There are, for example, if you treat the lungs, then some part of the lungs may have experienced fibrosis, which is stiffness and hardening, which we can see on the x-rays, but it does not mean that it becomes biologically significant, because we need to treat these areas. It's like doing a surgery. If there's a cancer, we need to cut it out, but you're worried about, if too much muscle is removed, I cannot play badminton anymore. But if the cancer is left to fester there, you may even have a chance of losing your limb, losing your life, and then not being able to do anything else. So there is a certain side effect profile which we develop with better laparoscopic techniques. In the same way, we give better and better treatment. Even the medicines that we give now, we now have immunotherapy, targeted therapy. They are more specific, and technology is just getting better and better, and we are being more and more targeted in the way we treat our patients. For example, the third big place that we treat and they have side effects, if let's say we treat pelvic cancers, and we do treat a lot of them in the abdomen, gynae cancers, patients may experience diarrhea, from treatment of the small intestines, large intestines. But now we have techniques called IMRT, where we can curve the dose and avoid dose to the small bowel and organs, and reduce actually dose to these areas. So the diarrhea rate during treatment now is conversely way lower than in the past.
I believe with technological advancement, there's definitely increased better cure rate as well. There's a question from Rafael. He's asking, is WBRT effective for brain metastasis versus using targeted therapy medicine to penetrate the brain or the blood carrier?
Okay, usually we do both. Whole brain WBRT means whole brain radiotherapy. Nowadays, we do even what we call hypocampal sparing, where in the brain, we can treat all of the brain, but we leave a area of the brain called the hippocampus, which is very crucial for long-term memory. So patients actually, after the treatment, have less cognitive decline, and whole brain radiotherapy usually is given if there is risk of seeding throughout the whole brain. We work with targeted therapy. It depends. If the tumor is very big, 5-6 centimeters, or 2-3 centimeters, targeted therapy will take a long time to actually shrink these tumors. So 2 to 3 weeks or 2 weeks of radiotherapy 10 times is very effective to actually focally boost these areas. And I've seen patients with tumors, and after three months, we see it shrinking very nicely. It also creates opportunities. It disrupts the blood-brain barrier, allowing the targeted medicine to actually reach into the brain. We have seen many patients who develop brain mets while on targeted therapy because the rest of the body shrinks. Why? The reason is because the brain is a sanctuary site. There's actually very little blood supply into the brain matter, and it diffuses in via the CSF, the cerebral spinal fluid. So circulation is being delivered to the brain, and then it diffuses into the brain. In this way, some of the cells which are seeded inside the brain gets very little targeted therapy, and the bioavailability of the drug inside the brain is very little. So radiotherapy is a way of reaching these pockets of large cells, but without doing surgery. So it is a way, depending on the patient. If you want a quick response, then probably whole brain or even SBRT to all these big sites with a boost is probably preferred. But I would not say that we will do both.
Okay, sure. I think we have one last question for tonight. So there's this question by Eileen. So she's asking, if the tumor markers showing at low readings, does that mean it should be safe to believe we are at the low risk site for the particular cancer?
Okay, so tumor markers have, and this you probably need to consult your doctor. Was your tumor marker high in the first place, specific to marking a tumor, and then you are doing it as part of therapy, and then we see it coming down, then yes, it's absolutely we can use that. But if you are just a normal person and who did a health screen and your tumor markers are low, it doesn't mean anything. We are not able to use the tumor marker to indicate that you have a low burden of cells or a low risk of cancer. It is just today your tumor marker is low. But of course, the converse is also true. If your tumor marker is high, means you have a high risk of a high burden of cancer at somewhere. If it's CA, then it's gut. If it's CA 15.5, then 15.3, then it's pancreas. So we go around looking for it if it's high. But if it's low, it's similar to saying there are no black swans. So until you've seen a black swan, we do not know. But if we see the tumor marker high, we have spotted a black swan. So in terms of, so there is a slight reasoning. The tumor marker is ironically only useful if it's very high. But of course, if it's high and it comes down, then we say there's a response to the treatment. But being low itself does not necessarily mean that I will not get cancer or I will not get a recurrence of it in the future.
Thank you so much for your sharing, Dr. Chin. Raphael says, thank you very much. Your explanation is very clear. And then we have a few things all coming in for Dr. Chin tonight. So thank you everyone for your questions tonight. And thank you, Dr. Chin, for your sharing and for answering all the questions from everyone here tonight. I wish you a wonderful Saturday evening and a beautiful Sunday ahead. So it's now time for Dr. Chin to take his leave. So once again, thank you, Dr. Chin, so much for your professional insights. Thank you.
Thank you, Carmen, for the invite. Bye-bye.
Bye-bye. Thank you so much for joining us tonight. And I hope to see you in the next session. Take care